Welcome everyone to the first instalment of IR Bites. This talk is on peripheral arterial disease. My name's Chris, the host for the evening. I really hope you guys enjoy this, whether you're watching it live or on catch up. This is the first of a 12-part series to hopefully teach you guys a little bit more about IR from the CERSI curriculum. Without further ado, I'll hand over now to Shian, who's an ST6 interventional radiologist in Southampton.
Hi everyone. Nice to not meet you, but anyway, I'll start my talk. So I'm really grateful for the introduction, Chris. I think this is a great initiative, and so well done for putting it all together. So I'm going to be talking to you about peripheral arterial disease, the subject on everyone's mind. So I've gone through the curriculum. There's not much there for you to really come away with in terms of hard knowledge. So I've included everything that's in there and just a bit extra and some fun cases at the end as well. So I hope you enjoy it. So the objectives of the talk are going to be to run over the relevant anatomy for peripheral arterial disease, the risk factors associated with it. We're going to be talking about how we diagnose it and the treatments. And I'm really just going to be talking about IR treatments because I'm not qualified to talk about the surgical treatments or the medical ones for that matter. And then I'll be doing that in the form of cases, really. Just to sort of forewarn you, I'm a really big fan of stock images. So just typing objectives in and getting an image like this, you'll get used to it throughout the course of the talk. So the anatomy, right. Peripheral arterial disease, when we talk about that, we're really concerned about lower limbs. That's all that's the main thing. And we're talking about chronic disease here. Acute limb ischemia is something that I'm not going to touch upon in this talk. It's a whole subject onto its own. So this is chronic disease of the lower limbs. Just going through the anatomy of the lower limbs, that's what we're interested in. We've got the aorta, which bifurcates at L4, splits into common iliac arteries here. They split into the external internal iliac arteries. And then we have the common femoral artery, which is the same as the external artery, but it's just as it passes through this inguinal ligament, which runs from the acis to the pubic tubercle. And then we're coming down here, common femoral artery splits into the profunda. Profunda means deep. And that deep profunda branch supplies the muscles of the thigh. And the SFA in a normal healthy individual, so superficial femoral artery, doesn't have any branches, but when it's diseased, it does. So it travels along here in the femoral canal, and as it passes through the adductor hiatus, so a hole, natural hole in the adductor magnus muscle, it becomes the popliteal artery. So we've got this posterior view here that you can see. And the popliteal artery, we split it into three parts, P1, P2, P3. You don't need to know that, but it just means above the knee it's P1, at the level of the knee it's P2, and below the knee it's P3. And then that splits into the anterior tibial artery and the tibio-perineal trunk. So that's a good name. So the anterior tibial artery is like a typical dog leg out through this interosseous membrane here, and it runs anteriorly, anterior tibial artery, good. And the tibio-perineal trunk is just the trunk where two arteries called the perineal artery and the posterior tibial artery arise. So that's the tibio-perineal trunk splitting in two against the perineal. They're easy to remember as well because the posterior tibial artery goes posteriorly. It runs medially under the medial malleolus through this thing here called the tarsal tunnel. And that's where you can feel the PTA pulse on yourself. So you can all do that now if you like. And the anterior tibial artery runs anteriorly along the forefoot, and that's where you can feel a pulse there as well called the dorsalis pedis. And the perineal artery sort of just fizzles out around here, and it runs in between the two. And you'll see that on the cross-sectional imaging that I'll talk about in a bit. So these are just some more diagrams, just with a bit more realistic anatomy associated with it. You can see that this is the inguinal ligament I was chatting about earlier, and that's the external iliac artery becoming the common femoral artery, the profunda branches, the SFA running down this femoral canal through this adductor hiatus, that hole in the adductor magnus muscle, round to the back of the knee where we've got the popliteal, dog leg out anterior tibial, the tibio-perineal trunk, perineal, which you can't see here, and the posterior tibial. And this is just some angiographic images. You're going to get sick of these towards the end of this, but I'll just go through the common femoral artery, profunda, and the SFA in a healthy patient with no branches. Coming down here, popliteal artery, dog leg out, anterior tibial artery, tibio-peroneal trunk, giving the posterior tibial artery here, and then running through the middle is the peroneal. So just try and remember that. It's fairly straightforward if you just take a little bit of time to remember the anatomy there. Now, PAD, as I said, we're talking about the lower limbs, and it's just the gradual build-up of atheroma within the arterial wall, and it happens over time. It just gradually gets more and more pronounced until you have a narrowing in the artery, which we call a stenosis. And the narrowing can get so bad that it becomes occluded. So those are the things that we're dealing with, stenoses and occlusions of these arteries. Okay, so I wanted to gear this talk around just you guys when you go on your taster weeks in your relevant IR departments, wherever you are. So some of the terminology you might hear is this, the aorta and iliac artery, so aorta-iliacs. It's commonly known as like the inflow vessels. They're supplying the legs. The common femoral, superficial femoral artery, popliteal artery, and the profunda, that's femoral-popliteal disease, well named. And then there's all sorts of names for below the knee. But mostly you'll hear people calling these arteries the tibials, the crural vessels, and the runoff. If you're trying to be sort of cool, you probably call it the runoff, I guess. I don't know. But those are the main terms you're going to hear. So the risk factors. So there are modifiable risk factors, things that you can change, and there are non-modifiable risk factors. So the modifiable risk factors for peripheral vascular disease, peripheral arterial disease, are diabetes, smoking, a high BMI, increased cholesterol, hypertension and kidney injury, and living a sedentary lifestyle. The non-modifiable risk factors, so here we go, stock images again going. So we've got being male, so this looks like a sort of a male who's just realised he's got a risk factor for peripheral arterial disease, quite somber there. You've got family risk factors, so it's for me if it runs in the family, so you've got a nice family here, and if you're old, you've got 2 old people. So I think those are good images actually, work nicely. And how's the diagnosing done? Well, it's done by, quite suave looking people in lab coats holding an iPad, and they assess the symptoms. They can do an ankle brachial pressure index, and then they can order imaging and they can read the reports on these little iPads. So the symptoms, I've put asymptomatic at the top there. Sounds a bit stupid, but I'll explain that in a bit. Claudication. So claudication, you may or may not have heard of that term, and it's basically like a muscular pain, so an aching pain that comes on when you're doing exercise or walking, and classically it stops, or it gets better when you stop doing the exercise. So you stop, you take a breather, and it's gone away, and you can start walking again. And actually where the claudication is kind of tells you what sort of lesion you might have. It can inform where the narrowings could be. So if you've got impotence or gluteal pain, you're maybe thinking aorta or iliac disease. If you've got thigh pain, then you're thinking it could be femoral-popliteal. And if you've got calf pain, it could be the crural vessels. That's really kind of loose, and you can have femoral-popliteal disease that should give you calf pain, etc. But those are sort of classically what you might think of as localizing symptoms. Rest pain. Now, this is a really important thing. That is basically pain when you're in bed. And what's happening is when you lose gravity, you're standing up, gravity helps blood get down to your lower limbs. But when you're lying down, you don't get that same help from gravity, and you get that ischemic pain again. So that's a real bad sign that you've got bad disease. And tissue loss. So that's the worst case scenario. You can have an ulcer, it can become gangrenous, you may have to lose a limb. So there are some definitions associated with it. So I'll just explain that asymptomatic thing again. So asymptomatic people, they can still have peripheral arterial disease, but they can live such a sedentary lifestyle that they never experience the symptoms. So if you never walk 200 yards, you don't get claudication. And for those people, you can do exercise tests. So you can make them walk and see how long it takes for those sort of symptoms to arise. That's something you can do. Rest pain and tissue loss is known as CLI. You'll hear CLI all the time. That stands for critical limb ischemia. And that means something really needs to be done for that patient. Now, this is in your curriculum. There are 2 classification systems for peripheral arterial disease that we tend to use. Fontaine and Rutherford. I don't think we use in practice, we're not very hard and fast with these sorts of things. We try to go on a more of a broader clinical basis when we're deciding patients to treat. But for just starting out, you should maybe have a look at this. So Fontaine stages, they basically mirror each other. So stage 1 or grade 0 is an asymptomatic person. And then the claudication, so this is claudication, walk in, oh, got pain, stop, Let's start walking again. It gets better. That's mild, moderate, and severe for Rutherford, and they've given a distance on it, so more than 200 yards or less than 200 yards being severe in the Fontaine classification. This is rest pain. So this is what I was talking about. You get pain when you're lying flat, and you need to dangle your legs off the side of the bed to help with the pain. That's gravity helping you out there. So that's rest pain, grade 4. Also grade 2, but category 4, stage 4 there. Now, this is where they differ. The major difference between the two systems is with regard to tissue loss. So if you've got tissue loss, you're stage 5 in Fontaine. If you've got a small ulcer, just limited to a digit or something, you're grade 3, category 5 in Rutherford. And if you've got gangrene, particularly extending beyond the metatarsal level, that's grade 3 or category 6 in the Rutherford. So it's worth having in the back of your mind. What you can do for asymptomatic patients or people with caudication is assess their ankle brachial pressure index. So this gives you sort of an indication as to how bad the disease could be. And I'll just talk you through it, how you go about doing it. There's a brachial artery in your arm, obviously, and that's where you normally take your blood pressure from. There's the dorsalis pedis in the PTA there, okay? So when you're taking your blood pressure from your brachial artery, you inflate a cuff. What we do here with ankle brachial pressure index, we have this Doppler probe which makes a noise that mirrors the flow, and we inflate the cuff, and when that is obliterated, that noise that you're supposed to hear, it means that the pressure of the cuff has squashed the artery, so it's overcome the pressure in that artery, and that, just as you do that tells you the force or the pressure within the artery. So you have a blood pressure of, say, 120 in the brachial artery, and then you put this probe down and the cuff over the calf. Do that down at the foot, so on the dorsalis pedis or the posterior tibial artery. And if it's 120 systolic again, then you've got a normal ankle brachial pressure index. So it's the ankle pressure divided by the brachial pressure. And if that's 1, that's great, normal. But if it's less than 0.8, then you've got peripheral arterial disease. So the pressure in the ankle is less than the pressure in the brachial artery. You've got peripheral arterial disease. Somewhere you're losing pressure along that system. If it's less than 0.5, so if it's half, then you've got severe peripheral arterial disease or critical limb ischemia. Interestingly, you can have really bad disease and have a higher ratio. So what I'm saying here, so if it's more than 1.2, it suggests you've got calcified disease. Now, what that means is you've got your blood pressure at your brachial artery, and then you're doing it down here. But because these vessels are really calcified, you're going to have to inflate that probe to a higher pressure to squash those hard calcified arteries and stop it from giving you flow. So the pressure in that in the foot arteries, dorsalis pedis, PTA, are higher than the brachial artery. So that's a sign of severe disease as well. So you want it to be in this sort of ballpark here, 1.1 to 0.9. If you find that difficult to understand, you can look at videos to explain ABPI. I wanted to do one, but no one would film me doing it. I've tried for a week, but no one wanted to do it. The next thing you can do is Doppler ultrasound. So this is a good investigation, good screening. It's non-invasive, but it gives you a lot of information about the artery. So here we've got an ultrasound probe, and this is Doppler flow, so it's color flow through the artery, okay? And it's giving you this waveform. You don't really need to know too much about it, but when it's like this, it's triphasic, up, down, up again. That tells you that the vessel, you've got good systolic pressure, you've got some elastic recoil, so healthy arteries, and then it's going forward again. So that's nice. And this is up at the common femoral artery for this patient. So up here, we've got good triphasic flow. Then we take the probe further down to the superficial femoral artery area, and we can see here that you've got no flow, no tracer, no flow, no color at all. So that will tell you that it's occluded, as somebody has helpfully labeled there. Now, this is the interesting thing about Doppler. What you can do, if you've got an occlusion or a narrowing, a significant narrowing, and you see that below that narrowing, so now in the popliteal artery, you've got some flow again. How that got there? Well, what's happened is it might be squeezing through a tight stenosis, or more likely, if it's chronic disease, new vessels will have formed around the blockage and reconnected with this popliteal artery. But that won't be good systolic, triphasic flow. That'll be really trickly, what we call here monophasic flow. So that's an indication you've got a high-grade stenosis that you need to do something about. And I'll just show you some angiographic images. Okay, so this is fluoroscopy. We're injecting dye or contrast into the arteries, and this is that level at the common femoral artery, and I'll just play that back to you. Triphasic flow going forward very nicely, and then down here, distal SFA blockage, occluded. You can't see any it should be going down there, but it's not. And you can see there's that little collateral coming off there. Where's that collateral going? Well, I'll play this. So this is at the level of the popliteal artery just here, and you can't see the SFA coming down here. Okay, you've got all these wiggly collaterals, and it's filling this faint thing here. That's the popliteal artery. And here are some colourful circles around the places you should have been looking. Okay, just see that coming in, and just a little trickle of blood in that popliteal artery there. So that's how you can assess it. We use imaging. The other type of imaging we use is CT or conventional angiography. I can take you through a CT scan. You can use MRI angiography as well, but CT is really what we like to use. So what I'm going to do now is hopefully not lose the connection and switch screens. Hopefully now you should be able to see this CT angiogram. So it's in the arterial phase because the aorta is nice and bright. So we've given contrast and it's in the arterial phase. So this is the aorta. We're going to come down here and it's got all this calcified disease. Doesn't look very good, does it? And these are the iliac. So splits in two, common iliac. And then that vessel splits in two again. And you've got the external, internal iliac. Coming under the inguinal ligament, it becomes a common femoral artery. Interestingly, this branch here is also another a marker that you've changed. So this is the inferior epigastric artery basically, and then underneath the inferior epigastric artery in the common femoral artery. So we come here, you've got some posterior wall calcification here, and splitting in two again, profunda, supplying the thigh muscles, SFA coming down here, superficial femoral artery, in this femoral canal that it's traveling in nicely, and then we've got that big collateral there coming off, and that's the occlusion. We've got disease on this side, but I'm just going to focus on this side because that's what the images we just looked at were talking about. So you've got this occlusion through that popliteal segment, and here's that collateral now filling that back up again slowly, and that's a popliteal artery. And we come back down, and this is actually not a good example of normal anatomy because you've got lots of blockages. So this is the tibioperineal trunk. If you can just believe me, there is a dog leg out, and that'll be the ATA. This will be the tibioperineal trunk, and there's the ATA filling again. That's the perineal artery, and the posterior tibial perineal artery, ATA down here, going down into the foot. So that's CT angiography. So that's sort of our workhorse. That helps us assess how we're going to be able to revascularize patients, CT. Good. So I'm going to now try to switch back. Okay, so you should be on here. So I'll just explain here as well. This is something called a reconstruction. So what we do is we can manipulate those images to twist them into the plane of the artery and get a nice map of the artery as well there. So that's what I've done there. And you can see that sort of marries up with the angiography. Good. Claudication management. I don't think you really need to know this at medical student level, but I thought I'd just put it in there because it's some facts. So for claudication, the main thing is to reduce your risk factors. So stop smoking, reduce your cholesterol, improve your diabetes, and reduce your blood pressure to a normal level. You can go on antiplatelet therapy as well. Once you do or do not have, if you do have symptoms, there are some pharmacological agents you can take to improve your symptoms, but if that doesn't work, you're going to have to come and see a vascular surgeon or interventional radiologist because you need to find out where that lesion is, and we'll do the CT or we'll do an MRA or we'll do an ultrasound, find out where the lesion is, and we'll revascularize you. You know, it's not very nice being confined to only being able to walk 200 yards every day. So that's what we would try to do. CLI, that critical limb ischemia, this is something that really needs intervention. And basically all we need to think about here is, are they a candidate for surgery or intervention or not? Because if they're not, then they're going to have to just have painkillers, and hopefully that helps. If they are, they can have revascularization, and if they can't have revascularization and they can't tolerate the pain control, they will have to have an amputation below the level of the blockage. So it's not very good news. So treatment options. There are lots of treatment options in interventional radiology and vascular surgery. It really depends on lots of factors. So it goes through the MDT, vascular MDT, whenever we have a case. Because these patients aren't just your normal patients. As you can see from the risk factors, they usually got high blood pressure, diabetes. They probably had a stroke before or a heart attack. So they don't make very good surgical candidates. So we make a decision, are they a very good surgical candidate or not? If they're not, then let's try the less invasive endovascular option. If the lesion's really long, it's probably not going to be able to, we're probably not going to be able to get through it endovascularly, and they will have to have a surgical intervention. If it's in the groin, the common femoral artery, the surgeons can easily access that area surgically and clear out the blockage via an open operation. So the open operations that they would do is an endarterectomy. If you don't know what that is, it's basically they cut down onto usually just the common femoral artery, to be honest with you. They make an incision, clamp the vessel from above and below, and they will pick out, it's a very delicate operation, actually quite satisfying to watch them do it. They just peel away the calcified disease from within the common femoral artery, and they will just either sew that back up or they'll sew on a patch to make it a little bit bigger. A bypass that is another option. So if you've got a long occlusion of one superficial femoral artery, for example, they can harvest a vein that you're not really using in the leg, provided you have one, and they can sew that on from above and below the occlusion. So that's the surgical options, really. So, if you don't have a vein, you're not a surgical candidate either. They can give you a sort of a graft, a PTFE graft, which is just sort of synthetic material graft, but they don't tend to have as good outcomes or longevity as just having a vein. So anyway, let's talk about IR stuff, because that's what we do. Going to case 1. So I'll talk you through what you can see here. So when we're accessing inside the arteries, we leave this thing called a sheath. It's basically a tube. It comes in several different sizes. It can be 4 French, and it goes all the way up. But for peripheral arterial work, it'll go up to usually about 8 French is the largest. We tend to can put bigger ones in for going northwards. And a French is basically 1/3 of a millimeter. So divided by 3, and you've got the actual diameter of the tube. And that sort of it's got this side arm where we can inject contrast through, and then we can go through this bit, which has got a little valve in it, and that's where we can introduce our wires and our catheters, so other small tubes through, and help negotiate arteries. So here we go. We'll start here. I've got an antegrade puncture. So antegrade means the way of the flow. So we're going down the leg, the flow is going this way. It's an antegrade puncture. It's a superficial femoral artery, profunda artery there. Doesn't look too bad, really, does it? And then here you go. You've all seen this lesion now, because showed it to you on the other cases. You got this knobbly disease, collateral, spindly collaterals, fills back in, popliteal. Okay, so that's the lesion we want to treat. And if you remember the CT, you remember that we had a bit of an ATA, anterior tibial artery, tibia perineal trunk, perineal artery. He's moved there, so you haven't got the best images there. That's the anterior tibial artery. That's the perineal artery. But anyway, so that's a normal angiogram that we would do, just to make a map of what's going on, what we want to treat. And we usually want to treat the most proximal lesion. So we'll have got across that lesion with a wire, and then we inflate a balloon just to open it out. And you can see there's nice result. You've opened that whole vessel out. So I'll go from where we were initially, look like that, and now it's nice and open. That's kind of where we left it with that, because we don't want to do too much. I'll talk about going into these vessels with some of the other cases. So case 2, we've got a 74-year-old male who's unfit, and he's got right CLI tissue loss. Okay, so just load that up. Okay, so again, antegrade puncture. What you'll see here, this is actually not a really good puncture by me. This is low. You got the profunda here, you got the superficial femoral artery, and I'm just punctured there. A good puncture is basically over the femoral head. You want to puncture right up here, because if you need to stop the bleeding, you can just press on that bit and it'll be against bone. You can stop the bleeding nicely. Down here, it's a bit loose and you won't be able to stop the bleeding, or might not be able to stop the bleeding very easily, but we can put a closure device in, those sorts of things. That can be difficult because the patient's got a large belly and I can't actually get up there. Okay, so we do an angiogram here, running down. We've got these areas of whiteness. Okay, you can sort of call them filling defects if you like, and that's just really hard calcium. Okay, that's calcium there, blocking up the arteries. Not very nice at all. It's like basically traversing the whole lesion, whole artery there. Not bad distally. We've got all this stuff here. And actually you can see this is the ATA, and it's knobbling down. You can't see anything past there. Knobbly disease in the posterior tibial, and that perineal artery doesn't look very good. Let's run down the foot. Now all he's got is that perineal artery between the two. The ATA should be here, PTA should be there. They're not there. It's just got that single vessel runoff. That's the terminology for it. And this is down at his foot. So this is a lateral view of his foot, and you can see not very much at all there to deal with. So that's probably why he's got really bad feet. So get across the lesion, it's very straightforward. You get a wire and a catheter across the lesion, and we managed to get through the lumen of this vessel. And again, looks a bit repetitive, but anyway, that's the SFA treated. The flow is much better, but this is what I wanted to show you here. It's got all of this stuff, okay? This is when you get down to below the knee, it's actually quite difficult to treat because these vessels are really friable. They're really sensitive. So if you touch it with a wire, they like to spasm, and they're narrow. They're about 2 to 3 millimeters, and sometimes even narrower. And if you knock something off, you can block these arteries off really easily, and then you're in a worse situation. And the artery we really don't want to damage here is the perineal, because that's the only thing that's going down to his foot. So we've got to take all this into consideration before thinking about treating him. This is a run of the foot after we just improved that superficial femoral artery. So it's actually already, you can see it's a lot better, but it's still not great. So get into the ATA, anterior tibial artery, with a catheter. Come through here, we think, shall we revascularize all of this? Yeah, why not? So I got across with the wire that's really thin. So normal wires come in a size which is 0.035, so 0.035 of an inch. These wires are even smaller than that, so they're 0.018 and 0.014 wires. So they're really, really small, like hairs. But there's a lot of technology in them, which I'll explain in a minute. And these catheters, so these tubes that you use sort of track over them, are really well engineered as well. They're tapered, they're slippery, they're strong in certain bits. They've got different shaped ends and stuff as well. So anyway, we get into this, got past that nasty ATA occlusion. We've got a long balloon here, and we've come all the way up to the top. Let's see if that does anything. Oh, not bad. That's pretty good, isn't it? That's pretty good. Opened it up quite nicely. It was nothing there before, so we've improved that vessel. I think, shall we just take that and get leave? Well, shall we see if we can get there? Don't know. Let's have a look. So we get in down here, and if you can just focus down here, it's hard to see. I don't know if it's projecting well, but there you go. We've got all the way down that non-existent artery, and injected contrast here. So we're down below at that distal PTA below the tarsal tunnel level, so that medial malleolus level where you're supposed to be able to feel a pulse. You wouldn't be able to on this guy. He's fidgeting a little bit. Long balloon up that again. Let's see what that does. We'll check on that in a bit. This is just me fiddling around trying to get into the perineal artery. Get in. Just angioplasty the top of that perineal artery. Looks like it's going to work. And there you go. Look, we've opened that up really well. So now we've got 3 vessels. We only had 1, now we've got 3. It still doesn't look great here. So an erupt end. We've not really got much going on in the foot. See if we can get past it. So we got all the way down here, and you can see through this mesh of collaterals, he's got an arch here. So this is really important. This arch is called the dorsal arch, and it basically connects the anterior tibial artery, dorsalis pedis, round here and then down underneath the foot to here. That's your communication in the foot, and everything comes off of there and supplies the foot. So if you can link this up, you've done a great job. It's almost like, they've got a normal circulation again. So managed to get one of those really thin wires all the way down there, which I was really happy with. And we've inflated a balloon. I mean, it's pretty straightforward. You just get across, inflate a balloon. But anyway, there you go. Hey presto. So from here, you can't see anything, to this. I think that's pretty good. And our completion run is this one. And this is just taken from the top here, and you can see that there's so much more supply now. It's coming fast and it's going everywhere. We've restored some of that arch at least anyway. So that's a pretty good result. So that's the tibials, and we'll just show you a bit of kit that we might use for that. So these are the things. I mean, this is only just, these just a few examples that I could find. So there's a lot of technology in these really fine wires that we use down in the tibial arteries. They have to be soft, they have to be strong, we have to be able to push them over a long distance. You can imagine if it was really flimsy, you wouldn't really, when you tried to push against a bit of calcium, it wouldn't go anywhere. And they've got like these really gnarly materials like skintanium, whatever that is. And there's, this is only 0.18 of an inch, and they've got sort of coils in here that makes it atraumatic, and they have weighted tips so you can drill through things. It's really quite impressive, the stuff that you can use. And I mean, it probably doesn't sound like a great deal of interest to you, probably not, but you can get quite nerded out by some of the wires and catheters that you can use down in these vessels, because the reason why I say that is because if you just went down there with a standard wire, you'd make an absolute mess and it'll be a disaster. So you start to appreciate these cool little wires. Cool. The next case, 63-year-old male again, right CLI. The histories aren't really that, they're all this right CLI, necrotic hallux loss as well. So he's got tissue loss, so that should be. So hallux means toe. Right, I'll just get that case up now. All these cases show a slightly different type of approach as well. So bear with me. Before you start going mad, it's not the same case. It looks similar, but it's not, okay? So you got antegrade puncture. Let's go down here. Profunda, yeah. And you got that occlusion. It's not the same case. Looks the same, but it's not. Okay, it's that other case that we saw at the very beginning, actually. So you got that popliteal filling in here, these collaterals. And if we come down here, poor supply down to the foot, that's just the posterior tibial. He's got really good posterior tibial, actually. That's pretty strange. And anterior tibial filling in late, it's not really that cool. So we get down to this level, and I want to try and get across the natural area, the natural path of the artery, which is occluded. We managed to get across. So the way you get across this, if it's occluded like that, is through the subintimal path. I'm going to explain what that means, but basically you travel through the muscular layer almost of the artery to try and get across, and then you break back into a healthy part of the artery. So you saw in the image before that the popliteal was healthy. You try and break in around the popliteal area, this knee area, into normal artery again. And that's going to leave you with a problem, because you've got this, you're not gone in the natural hole, you've gone through, you've bypassed it in a way. And I'll show you what that will result in. But anyway, do some more runs, blah, blah, blah. I'll skip through some of these ones that aren't really that important. So we get across and we angioplasty up where we've come, and inflating some balloons. Let's do a run, see if that's worked. That should have worked, but it hasn't really worked. And you won't be able to see this properly. I think actually you can. But here, there's that little filling defect again. So this sort of whiteness, and it's sort of vague, it's not really well defined, not like the calcium we saw earlier, which was really well defined. There is some sort of filling defect here. Remember I told you we went subintimally, okay, through the wall, and that is just a flap that's been lifted up, that's wafting around in the artery, and it's not flow limiting because contrast is getting through it, but it could flap over and shut the whole vessel down, which is a bit of a problem. So we need to really address that. So what we normally do to address that is try and tack it back down. So we just inflate balloons again, try and tack that thing back down, and hopefully stick it back down so it doesn't go anywhere. But actually, it's still there. So this is really annoying. Can't really leave it like that, I don't think. So try again. Desperate now. Please go back. It won't go back. Okay. So then we put a stent across it. So these are bare metal stents, and there's all sorts of different stents again, and they're all useful in different ways. This is something called a superior stent. You don't really need to know it, but it's quite flexible and it's really strong. So it's good for these sort of parts of the artery where there's a lot of movement. Okay, so this is the adductor canal coming up here. That's where you bend your knee a lot and you get a lot of movement. So that kind of needs to be strong. So that's a superior stent that we've deployed there. And you can see now, oh, that looks pretty good up here, doesn't it? But actually the flap's still going on down here, which is a bit annoying. We can't really leave that, so I end up putting another one in, and there you go. So this is slightly smaller because you don't want one the same size arteries get smaller as they go down. We've put a stent within a stent and we've got good flow there. Okay, so that's that. I don't think we need to go on any more on that case. Let's just talk a little bit about the things that we use for that, or the techniques that we use for that. So So this is something called this is basically what we did here. So this is subintimal dissection. It's a diagram I found off of this case report of just what subintimal dissection really looks like. So what happens here? You've got the intimal layer of the artery and this occlusion. You've got the media, so the muscular layer, and then you've got the externa, tunica externa. So what you want to do is go. You can't get through this. It's blocked. The wire won't go. So you've got this occlusion here. So you dig your wire in underneath the intimal layer and try to take a loop down. So you bunker in with the sharp end of the wire. You take this loop down, which blunt dissects its way down that subintimal tract. You can see here, so it's dissecting its way through that subintimal tract. And then when you're back in normal lumen, you bust back out of there. Okay, that's actually a lot harder than you think to just get back into the lumen where you want to get back into the lumen. And you've got this nice channel now. And what you can do with that channel is exactly what I did: inflate a balloon, squash all this stuff back, and see if that works. If it doesn't, you have to put a stent along this to make this channel the new channel that you're going to use. And we didn't use this in this case, but there are lots of things. As I said, remember I said it's not very straightforward trying to break in where you want to break in, and you want to break into the lumen. So there are lots of these cool devices that you can use to do that. This is something called an outback catheter. So basically you come down this subintimal layer with where your wire is with this catheter, and then you orientate it using the imaging so that you think you're pointing into the lumen, and then you flick out this needle into the lumen. And through that needle, a really fine wire will go into the lumen. You take this out over the wire and you've got your access back into the lumen. So that's really good. There are other ones where you can inflate a balloon and puncture rack into the lumen as well. There are lots of devices where you can do this. So it's quite interesting, I think. Right, the next case, 70-year-old male, bilateral claudication. What a surprise. Right, let's get this case up. So I would have just put these in the presentation, but you don't get the same quality of imaging when you just put cine loops on. So I think it's better just to use the PAC station that we have here. Okay, so going through the CT scan of this patient with bilateral claudication. Okay, so you've got the aorta. Let's whiz down here. Don't worry about all this sort of stuff. Calcified, they're quite narrow. And you've got this calcified disease of the common iliac. Someone's measured this, but you can see, look, oh, that's narrow, that's not really good. Look how big the patient is. He's really narrow iliac arteries, calcified. You can barely see a lumen there. That's barely see that there. And he's also got disease there, all the way down his iliacs, basically. Doesn't look very good. So what we're going to do, well, we're going to have to treat those. So this sort of area is really hard for surgeons to get to because the patient's really quite large, so getting down to them is an effort. The vessels are really small, they're calcified, so calcified vessels are a nightmare for surgeons because they can't really clamp down on something. They're really crispy and friable, so they've got no area to really clamp to get control. They have to, when you're dissecting down into something, you need to control the blood flow, so you have to put clamps around it, and you can't really anywhere here. And the bypass option would be to sew something onto a nice healthy bit of aorta, maybe there, I don't know, that's really high and difficult to get to, and then plug back into a normal artery somewhere down lower. It's not a good operation. So we can do something endovascularly, obviously. So what we'll do is, this is littered with measurements that I'm going to kill Tom for. We've got bilateral retrograde access. Okay, so now we're going against the flow of the blood. Yeah, and there's our sheath here pointing upwards. So we've got into the common femoral artery pointing upwards. This is a hip replacement here. Tom's managed to negotiate wires already up into the distal aorta here, and he's put a catheter across up one side and injected contrast. So now we're getting flow from the top all the way down. That's what we can see. Now you can see, this doesn't look very good. That's narrowed there, narrowed there, narrowed there. This is really narrowed. That's really narrow. Doesn't look very nice at all. So we're going to have to angioplasty this or stent these. Now, you don't need to know too much about this, but there's a current theory is basically when you get in the iliacs, you need to stent first. Angioplasty isn't really enough. You also need to be really careful about how you size the stents, because if you make them too big, they're calcified. So that calcium has to go somewhere. If you push it out with an oversized stent, you could rupture the vessel. And if you rupture that vessel in a really large person, or in anyone for that matter, and cause high volume bleeding in the retroperitoneum where those arteries lie, the surgeons aren't going to be too happy with you. So you've got to be really careful. It's quite dangerous territory here. although technically quite a straightforward procedure from our point of view, but dangerous. So get across, and these things are balloon mounted stents. So before I did that superior stent, it's that sort of stent is a stent that's inside like a sheath, and then as you pull the sheath back, it unravels and forms its shape. That's called a self-expandable metal stent. These stents are crimped down onto a balloon. When you inflate the balloon, they assume their normal size, and then when you deflate the balloon, they're stuck onto the vessel and they're open. So that's what these are. And you use these to get, so he's inflated one there and one there. You can't really see it here, but you see it on the digital subtraction angiography, or DS, and you can see now that's really opened up quite nicely. He's put those balloon expandable stents there. And these are really good because they allow you to be very accurate. You just put the balloons where you want to, you see the markers, and you deploy them and they stay where you want them to. If you're having to pull something back to unsheath it, you can imagine that you will move the vessel a little bit, which isn't ideal. So that's good. So we've still got more disease here, down here, more disease down here. So he's angioplastied that, doesn't really work. So he's that's a self-expandable stent he's done there. It's still a bit crimped, so he inflates the balloon. And there you go, you've got another one there as well. Like self-expandable metal stent there. Cool. Right. So you can see that's really improved the flow down. So hopefully you should get some benefit from that. Okay, so I'll just explain these stents. So these are the balloon expandable stents. Like I say, they come crimped down, and when you inflate the balloon, they form their normal size. And they're really good so you can be accurate. So if you've got a lesion right up there, the aortic bifurcation, if you're not very accurate with your stent and you deploy it a bit too far up, then you could shut this vessel off. The force of this stent can shut a whole other limb down. So you need to be very accurate. That's a perfect placement of the of a balloon expandable stent there. Right, this is just a really cool toy. So I just wanted to throw this in here. Same as your old mayor, right CLI, whatever. He's had a stent before for his CLI, and he's carried on smoking. So when you have a stent, you need to go on dual antiplatelet therapy, like you do for a heart stent, and you have to stop smoking, otherwise it will block. That's exactly what's happened in this dude. So we'll go to that case. Okay, so really quickly, I won't labor the point, but let's start here. You can just about see the stents here, there and there, and it's completely blocked. You've got this little cone that you can dig into here. And what we've done is we've got sort of just a machine called a Rotarex, cool name. And what it does is it just bears a hole through that. We've got across it with a wire, and it just sort of carves out a lumen for you. So there you go, there's that lumen that we've just carved out. And then we balloon that lumen as well, and then we're left with this, a nice patent stent again. That's the device. So this is a Rotarex device. There are lots of these kinds of devices. It's got a little gate in here, a corkscrew, and then it's got a little window. So it sucks this corkscrew creates like a vortex, and it sucks things into it. If you can look over here, it will just munch its way through this sort of stuff, taking all the thrombus away or the clot away through the channel. So that's a really cool device that we can use. So this is another chap with bilateral cortication. I think this is a really good case, so I'll just share this one as well, even though we are pushed for time. So I've put on my notes here the ultimate inflow case. You probably will never see a case like this. So here on this screen here, I've got basically this is MPRing, multiplanar reformatting, and we've got a sagittal view, so down the sagittal axis, coronal view down the coronal axis, and an axial view. Okay, and I'll try and skip to the interesting bit. This guy's got bilateral cortication, and he's got this complete occlusion of the aorta, and it's calcified. Look at that. Eagle eyes amongst you might see, oh, he's got a little bit, we could probably get through that. Short, no. This is a really, really hard operation for anyone to do because it's a high occlusion up by the kidneys. Not very good. And you can see here on the sagittal reformat, there we go, it's completely blocked and it's calcified. How are we going to open that up? Don't know. Well, I'll just add to that as well. He's got this iliac disease as well. He's got this nasty calcified external common iliac disease as well. So got to treat that as well. So my colleagues Drew and Mo tackled this. They came up with an interesting solution to the problem. They tried to burr their way through it because they saw this little soft bit through the calcium. Maybe there was a gateway through, and I'll run through these images for you. Just keep into the interesting ones. Bilateral retrograde axis again, flush. That is completely occluded. This is a distended lumbar artery. So the aorta gives rise to lumbar arteries, and that's the way he would have been perfusing himself. They would have bypassed the occlusion, gone around these lumbar arteries, back down and into a normal bit of vessel. So that's what that thing is there. Managed to wiggle a wire through there, put a big sheath through there, and he's burrowing his way through, and they're through. So you've got a sheath within a sheath within a sheath. So there's like a Russian doll kind of model. He's really trying to push through. Managed to get through, which is incredible. This is a hybrid case with vascular surgeons around, by the way, because things could go very wrong very quickly. Remember I said about calcium, when you try to expand it, it's got to go somewhere. And if we try to angioplasty this now, it could be disastrous. This balloon is called a lithotripsy balloon, I think. Well, they use the lithotripsy balloon on here. I'm going to explain what that is, but basically, once you get through, it allows a shock wave to go through the calcium, and it breaks it up into small bits inside the arterial wall, so that when you do inflate a balloon or a stent, that should be squashed back nicely into the arterial wall. So that's what they've done there. Got through. Here we go. Measuring stuff. Need to be careful here. And the patient's fine. Good. There's a stent wide open. That's brilliant. And they use those balloon expandable stents again. Bit more. These are the balloon expandable stents. Deployed them. When the stents are in this formation, it's called kissing stents, kissing iliac stents. So they meet in the middle of inside the aorta, and what that helps to do is the radial force of each one of them doesn't shutter the other ones. You place them at the same level and they'll stay there. If you put one higher than the other, or it will shutter it. So that's why that's important. And I'll show you the CT scan quickly that they did just afterward, and you can now see that he's got a patent stent. That calcium's actually kind of like just crushed out the way quite nicely with that lithotripsy, and you've got those iliac stents there keeping everything going. So that's a brilliant case. We'll rush through this last one. So this is a lithotripsy. You underinflate it, this medial wall calcification gets blasted with the shock wave, and then when you come through with a higher pressure balloon, it will sort of squish it out basically. Case 7, this is the last case now. Okay, so I know you guys are getting bored, but I think this is an important lesson, because I've just showed you cases where it's all gravy, everything's gone really well, really hard cases that go, but these things don't always go really well, and there are risks associated with doing endovascular procedures. It's not low risk at all. Go through this one for you quickly. So here you go. This patient has got, run down here, I'll go to the interesting bits. Okay, if it loads. So we're worried about this side, but I'll just go to tell you what this is here. So this is that bypass I was telling you about. So onto the common femoral artery, he's historically had a bypass onto the common femoral artery. So they've taken a vein, they've sewed it onto the common femoral artery, and he's now got this new channel down on the left. And they sewed it on distally, okay? But on this side, he's got this occlusive disease. So this is what we call a flush occlusion. So when an artery bifurcates and it's occluded, one of the branches occludes, a flush occlusion. So there's a profunda. The SFA's gone, completely gone. It's completely gone, okay? It's a really hard case. It comes back in later at the popliteal artery. And I'll just show you what the angiogram looks like for that. Okay, here we go. There's no SFA, should be here. There's all these mad collaterals. There's the popliteal artery. So what you want to do is break in at some point and get into that, okay? I'll just show you this as a reference. These are his crural vessels. They don't look too bad. Remember that they don't look too bad here. They look quite bad there, but you know. Right, so after much digging around, we manage to get through, and it's really hard. I'll tell you, that took ages, okay? And you inflate a small balloon, it wouldn't take anything, couldn't track anything bigger, because it's hard to push things through spaces that don't exist. So you have to use really small balloons at first. Nothing's working. Look, that's not working. Try and get across again, put a bigger balloon, not working. Get across again and do another balloon. Now we're angioplasting with a proper size balloon all the way up. Hopefully that's going to work. No, nothing's happening. In fact, let's try again. Let's try. It's got to open up with inflated balloon. It's sort of getting there, but not really. And actually this one now shows that where we had a popliteal artery before, it's gone. So we lifted a dissection flap, which has shut off that artery. That's a disaster. So what we've done is deployed a stent in the lumen to try and open it up. This is that superior stent. Tried to go again. Okay, nothing. And more stenting, nothing. It's really widdly. And now look what's happened. Remember those tibial arteries before? I'll show you them up here. That's what they looked like before. Now they look like this. Some clot has flown down them. So he's in a worse situation now than he started. That's not great at all. But what we can do is try, well, we've got to solve the situation. This thing is called an angiojet. I'm just going to explain what that is, but you traverse the vessels with that, and you basically suck out acute thrombus. So it's nice and soft, that acute thrombus. And we're sort of back to a better situation now. We've sucked a lot of it out, but still not out of the woods. So he will have to go on heparin overnight to try and help that situation. So that's this. Okay, so there's lots of these devices. The angiojet, what it does, you go across with a wire, you lace the area with thrombolysis agent, which impregnates the thrombus, and then you go through it again and you suck it out with this vortex. Other things like the penumbra device, you've got a suction thing here, pass that down, you try and suck out the acute thrombus as well. There's lots of these devices. These are just two we use here. Good. Case a million, because that went on for ages. I have so many more cases. We do joint cases with vascular surgery all the time, where we'll angioplasty a bit and they'll bypass a little bit. Lots of that work is done in hybrid theatres, which we are lucky enough to have. Most places are now. But it's a really interesting field, and I hope you enjoyed the talk. Thank you.
Thank you so much, Shian. That was absolutely fascinating talk. Thank you. We've just got a couple of questions from the chat. So one quite specific question, just asking about the length and diameter of the balloons you use for a below knee angioplasty.
So below the knee, you can go up to about 3 or 3.5. It really depends. If you've got a little lady, you probably do a 2.5 millimeter balloon. They pack down really nicely, so you can get much longer lengths. So what I should say is the size of the balloon means it has to go through a bigger sheath. So you don't want to be making a bigger hole in the artery if you don't need to at the top. These are really small, so they'll travel down. You can get them nice and long. So they can be anywhere up to 200 millimeters long.
Cool. I hope that answered your question, Mustafa. And we've got one more just about anticoagulation after stenting from Maria. She's asking, do you always put them on DAPs lifelong, or is it sometimes a bit of a different?
Well, I think that's an interesting question. I think it's sort of changing a little bit. It used to be for life, yeah, you used to have dual aspirin, clopidogrel or ticagrelor, but now people are starting to use DOACs, and I think it's a real area where things are changing at the moment, and probably when you've graduated from medical school, it'll be completely different. But they do need to be on some antiplatelet therapy.
Shian, can I ask a quick question about the fifth case where you used there was the in-stent stenosis and you used the Rotarex to go through? Is there a relative risk of distal embolization with that, or is the vortex again is kind of sucking everything up? Have you ever seen distal embolization with that?
We have not seen it, because it creates that, like you say, that corkscrew inside creates a vortex and it sucks things in. So we haven't seen it with that, but there are other devices where the blades are on the outside, and there is a risk of you, as you're winding down, that you cause some distal embolization with those ones. I mean, I've got to say that case looks really cool that we opened it up, but it doesn't always work. Those devices are really dependent on a lot of things. Like, it needs constant flow, it will short out, it can't get through calcium very well. So it might look good, oh yeah, you can get through anything. You can't always. It depends on a lot of factors. That's a case where it worked really nicely.
I think your sound effects as well, man. Maybe made it sound better than well.
Awesome.
Yeah.
So I think we're probably come to the end now. Thank you so much for running this session, and I hope to have you back for a future IR Bite. Next week we've got, I believe, fibroid embolization from Dr. Indrajit Mandal. So make sure to tune in next week.